Everyone to our first autumn semester conversation about research ethics. So this is a program that is run by the Center for Ethics and Human Values. It's done in support from the OSUMC Center for Bioethics and the College of Public Health, and is generously funded by the Office of Research. I am so excited about today's panel. We have Kayte Spector-Bagdady, who's coming from University of Michigan, who is the Chief of Research Ethics Services at the Center for Bioethics and Social Sciences and Medicine there. Then we also have an esteemed panel from OSU, including Dr. Tim Huerta, who's in family medicine, and also the Chief Research Information Officer at the College of Medicine and the Wexner Center. Amanda Rinehart, who's the university library, who's from University Libraries, is like the life science librarian, and Efthimios Parasidis, who is part of the Moritz College of Law and the College of Public Health. Whew. Okay, so welcome to everyone. So we're going to be talking today about data sharing and the ethics of data sharing. It offers so much promise and for the promotion of health and well-being. We've seen many occasions of that during COVID-19, but it also introduced many risks and potential threats to privacy, and challenges to informed consent, and the commodification of personal information. So in this panel, we're going to be discussing the risks as well as the role that universities like OSU should play in safeguarding individual rights and in equitably distributing the benefits and burdens of research. And so what we're going to be doing is we're going to be starting with Kayte Spector-Bagdady, and she's going to give us sort of the law of the land for 10 minutes, introduce some of the big key ethical issues that she's seen in her research and in her practice. And then we'll head over to Tim, Amanda, and Efthimi to sort of respond and talk from their experience and research, maybe also at OSU, in the OSU context. I have a set of questions that should take about 20 minutes. I have a set of questions that we've sort of looked through and discussed that we're going to start the conversation. And then we're going to open the floor, hopefully the last 15 minutes, to Q&A. So you'll see at the bottom of your screen, there's a Q&A chat. Please feel free to write questions as we go, and I'm going to field those questions as we get closer to the end of the panel. All right, Kayte, you're up.
Hi, everyone, and thank you so much to Dana, as well as all of her colleagues from OSU. It's a really excellent opportunity that I have been very much looking forward to. Okay, so everybody good? Everybody can see my slides? Great. Okay, so I'm going to talk to us today about the theme of the panel, obviously, the ethics of data sharing and research. And as Dana mentioned, I'm going to speak from the perspective of somebody who does research on research ethics and secondary research ethics specifically, as well as in my role as the chief of our research ethics service through the Center of Bioethics at Michigan. Brief moment for my funding. As always, important to acknowledge my funders at NIH. Thank you very much. So here is a brief summary of my arguments. So one, our biospecimens and health data are governed, regulatorily governed by method of procurement, how we bring them in. However, what contributors, where those data and specimens come from, contributors care about use. Biospecimens and health data that are procured differently end up being used in the same ways. And our current regulatory mechanism and the market mechanisms have failed to reconcile this tension between the way we value how we govern these with what people actually value who are contributing them in the first place. So this is a very brief overview of governance. HIPAA governs identified data collected clinically, generally. The common rule governs some identifiable research, so generally nothing that's de-identified. And maybe FDA, FTC, CMS have some involvement in commercial data that's flying around in the background. And if you want more information about that, I would refer you to Efthimios' fantastic New England Journal article about it that is cited there. But we also know that what contributors, or the people this stuff is coming from, care about is use. They don't care about how it was collected in the first place, right? We know that many people think that there should actually be formal opt-in consent to secondary research with their health data. Almost half of patients who are Black or Hispanic think that this should be true. We also know that often people feel that way about even de-identified medical information. People are particularly uncomfortable with insurance companies having access to their data. And this is a study I love from one of my colleagues, Dr. Ray DeVries. And in it, they were trying to figure out whether people would consent to broad consent mechanisms, saying you can do whatever you want with my data. So they asked people, would you sign this really broad consent about secondary research with your data and specimens? And about 70% of people said, yeah, sure, that's fine. You can do whatever you want. And then when they went back and gave examples of controversial research, such as what if we were researching weapons of mass destruction? What if we were researching better methods for abortion? 70% of those people then changed their mind and said, oh, I didn't actually really understand that. No, please don't use my data. So the thing is that even though these things are being governed by the way the data and specimens are coming in, whether they're research or clinical or commercial, they're getting all mixed up after they come in. So one example is that universities are actually commercializing data and specimens that we bring in from our patients and our research participants, and some universities sell that to private pharmaceutical companies. The other research that I did was on academic genetic researchers specifically, and we were looking at the increased use of commercial data by academic researchers. So that first dark blue line that's on the top of that graph is all genetic publications in the academic literature with private data. That second lighter blue line with the triangles is research done by academics with private data, and that bottom green line with the square is research just with private industry practitioners. So you can actually see that it's academics that are driving up the use of commercial data sources in academic publications. So some of this makes sense in terms of our current regulations. So our current regulations, so there's a lot of detail on the slide, but the important takeaway is that regulations describe what has to be in the informed consent document, as opposed to the informed consent process, which makes some sense because, you know, government investigators aren't there for every conversation, but you can actually look and make sure things were written down in the document. The problem is that we know that the only thing that actually works is the conversation. So to highly regulate the document and not at all the conversation, isn't that actually helpful? And so one of the things that we have been doing to try to move the needle a little bit at the University of Michigan is we have designed a new ethics committee, much like the one that Efthimios recommended in his New England Journal article, that actually looks at all of the data commercialization requests from industry of Michigan data. And so we're more protective than the regulations require in 3 ways. One, we make sure that people consented to commercialization of both their biospecimens and their data, whereas the regulations somewhat bizarrely only require that for biospecimens. Think of that as sort of the Henrietta Lacks response, right? We don't grandfather in data and specimens that were collected before the regulations passed, so everybody had to have consented. And we review requests for even de-identified data because we know that data is becoming more readily re-identifiable, even if we pretended like it was de-identified. So we review all of them to make sure there's consent. Here's the problem. So yes, we have raised the bar. I'm proud of our institution. I'm glad we did this. And the problem remains that when we do research, so this research was qualitative work that we did with patients and their clinicians who are enrolled in one of our precision medicine protocols. So this is patients and their oncologists. And so below is the requirement in the regulation that we disclose future commercialization. This is an excerpt from our informed consent form where we really went into a lot of detail about this might be commercialized, you feel comfortable with that, you consent to that. And then we went in and we started talking to patients and their doctors And actually the goal of the interviews was to talk to people about how they wanted money spent that the university brought in from commercializing data and specimens, and whether people would feel more comfortable if it was reinvested in research or, you know, should be given to the football team. Like, what do people want us to do with that money? And, you know, my study coordinator went in and came out of the interview the first time. She's like, Kate, I think we should talk. And it was because what we found was actually people hadn't read it. People didn't understand it. People didn't even know they'd consented to it. So here's a quote from one of our patients that said, when my study coordinator asked about commercialization, she said, well, I hope you don't, because I didn't think you said you would, or did you? I don't remember the informed consent form. Well, I get my lawyer because you promised that none of my personal information would be given to anyone outside the university. So this is under the new informed consent process. This is her doctor. It says, sorry, I have to move my people. It says, I hope we aren't selling it to 23andMe. Patients trusted in us that we have a trial where we're the sole people in charge of their information, and then after the fact sell it. I would have a problem with that. I would think that we would need to have a secondary approval for patients. Like we had, right? So those are some of the existing problems. So that's in academia. Now, if we're looking at the commercial industry, what we actually find is that the commercial industry is just banging through those informed consents, through those terms and conditions that everybody agrees to as they click through to their favorite wellness app, right? And so some work from Kirsten Osler, who's at Rice, who's fantastic. You know, only 1 in 1,000 customers click on a privacy policy. They look at it for about 30 seconds. They rarely read terms and conditions, but who these people are really suspicious of is people like us, is the academic researchers. Those are the people that are suspicious, not this, you know, pregnancy app or this fertility tracker app. So one of the challenges that we have right now is this tension between the amount that academics have to go through versus the amount that private industry has to go to, is actually these regulations in a way are actually incentivizing privatization of our data because it moves so much faster. So as an example, the All of Us research program, which was established under President Obama, the idea is for it to have like this diverse cohort of participants with their full genomic data that we can do really participant engaged research with. They have between 100 and 200,000 fully enrolled participants now. And there has been 2.16 billion allocated by Congress to build this cohort. However, 23andMe, on the other hand, has over 10 million people. 80% of those are white and well-educated, as opposed to 80% of all of us being diverse and underrepresentation. And 23andMe has a valuation of 2.5 billion, as opposed to spent. So there are lots of problems with this system. I'm just gonna highlight the most important one that I think is that a couple things. So when academics are getting their data from private industry, it allows private industry a gatekeeping function in what kind of research is allowed to go forward. Another is it limits researchers' ability to validate work or build derivative discoveries, right? You can't build on work where the data aren't accessible. And it also might result in decreased future access. So using 23andMe as an example, you can currently apply to use their data, and often they share it for free. However, in the future, if 23andMe gets sold or something, and changes her mind, those data might not be as accessible, and people have learned to rely on accessing them. And if you're interested in sort of the implications of some of this, there's a lot of good work around the Myriad case that I would suggest you refer to, and I'm happy also to talk about that in the Q&A. So just as sort of like a summary of the, as a conclusion of the problem here, so the human subject research regulations left open whether we are going to consider biospecimens inherently identifiable for research. And what that means is whether we are going to have to ask for informed consent for all biospecimen research, because we're assuming that it can't be de-identified. So we're always going to have to get consent. So one thing this further sort of propagates, so that's the wonderful new portrait in the portrait gallery of Henrietta Lacks, but it does sort of propagate this odd tension between why are we so protective of biospecimens and not of the data derived from the biospecimens. And so the JAMA viewpoint that I have there is recently by Francis Collins earlier this month, saying we should close this loophole. We should ask for informed consent for biospecimens, and whether that will further enable the privatization that we're struggling with. If academics have to follow these very strict requirements for consent, but private industry really doesn't. So this is my last slide, and some ideas about solving this problem that I know I'm going to refer to Tim and Amanda and Efthimios to talk more about, and I would certainly really enjoy their feedback. So this is unlikely to have a regulatory fix anytime soon, right? We waited 25 years and then 6 more to do it the last time. So that ain't gonna happen. So what can we do? One thing is that we can potentially change academic standards. We can require that researchers know the pedigree of data and specimens, and that is already starting to happen. And we can raise all boats by setting the baseline standard of what we ask people to consent to higher. So instead of being like, well, if people consent, it must be okay that we're doing this crazy thing. We could say, well, we know most people wouldn't consent to this, and we know most people don't read the informed consent form. So let's set the standard higher in the first place. And then another good place I think we could look is journal standards. So requiring researchers disclose where they got this data and specimens, I think could be really helpful. And we've actually seen articles retracted recently because of where people got their specimens. Like a classic example is from Chinese prisoners. But this really could, there could be a lot more that's done, as well as reporting the type of informed consent. Because in my work, when I've surveyed articles that were published with private data, only about half of the time do the researchers actually report the kind of informed consent that participants gave. And it might be waiver, it might be nothing, but usually they don't even know. So that is the overview. I'm really looking forward to everyone's response.
Great, thank you so much, Kate. And so now we're going to let Tim Huerta go first. And I think that Tim also has some slides to share.
I'll be quick. I just need to, someone needs to stop sharing. There we go. I can't share slides when other people are sharing. Perfect. Hello, everybody. For those of you who don't know me, my name is Tim Huerta. I'm the Chief Research Information Officer of the Wexner Medical Center in the College of Medicine. I'm also a professor in family and community medicine and biomedical informatics. And I assume you all can see my screen. I'd like to talk a little bit about what it's like doing research at OSU and what the data landscape looks like, because I think these are the day-to-day issues and dynamics that researchers face in the context of what's going on, and also some of the enabling infrastructure. I took this role almost a year ago, actually, a year and like 2 days ago. And we've done a lot in preparation for the shift that we're going to see, that I'm hoping will take place at OSU in January. So for those of you who don't know, I'm going to focus a little bit on our clinical data I'm going to focus on our clinical data. For those of you who don't know, we're an Epic shop. That is the purveyor of our EHR. And Epic effectively has 3 data sources that are generally used in research. Chronicles, which is a transactional database that says everything that everything does, everything that everyone does in Epic is recorded in Chronicles. Clarity, which is a relational database that comes from that. And then Caboodle, which is actually a simplified model that standardizes definitions more rigorously. And one of the advantages to Caboodle is that you can move data into Caboodle from external sources like the cancer registry data. Epic, as an institution, as an industry leader, is in the process of building tools based on an opt-in system where it's leveraging this data in systems like Cosmos, which are effectively looking at things like the outcomes associated, de-identifies all of the data, puts it into a data lake, and then has tools on top of it to allow people to know things like, how did people react to particular drugs? You won't know how that person will react, but you can see the distribution of the way that people react. And so it's really using the EHR to understand how similar people might react to different, let's say, treatment regimens. And so there is a clinical model that is underlying a lot of what we then expect to replicate in the research environment. So these data sit in these data sets, and researchers generally want to impose some analytic framework on top of them. Things like machine learning, artificial intelligence, and the like. I will tell you at a broader level, OSU's vision for how we're facilitating access to data is to do what the census has done, and what actually IUSPR at Michigan has done, which is to create a secure enclave where there exists a synthetic data set. That synthetic data set doesn't match any human data. And you run your analysis against that framework. And if your analysis works against that framework, you then submit that analysis, that framework analysis, to a third-party computer system, which analyzes the data, and then you get your results back. So you actually never get to see the data, right? But you get your results. And this way we open up transparency, and we engage, we still have rigor and reproducibility because the structures are there. Additionally, we're in the midst of developing a secondary data core, which includes things like the American Hospital Association, the HCUP data, the CMS data, market scan data. I forgot all of us, because when you said it in your presentation, I'm like, oh, I just remembered that's on the list. Where you'll be able to also run your queries against those data where the ontological dynamics match. So if you're doing analysis on, let's say, ICD-10 codes, and those codes exist in other data sets, we're hoping to create systems that automatically analyze those secondary data sets, because there is, in the area, and NIH's concerns around rigor and reproducibility, just because you find it at Ohio State doesn't mean it's true. And intersubjective reliability would say that if it's true in like 5 other data sets, it is more likely true than if it's just true in the population of people who are served by Ohio State and Central Ohio. So I think that there are models that are out there that give you access to being able to ask the questions while not exposing you to the actual data. And I expect that these models, I look at the N3C collaborative, I'm looking at a number of efforts that are up and coming in the kind of research environment more broadly. And there really is this acceptance of using synthetic data set models in concert with secure enclaves to protect the actual data, but to give people access to things that, to give people access to resources to answer their questions. There is an ongoing conversation that we haven't gotten about, but I think what's in your first slide, which is really this distinction between PHI and RHI. That there is a class of information that that people are identifying called research health information, because if you think about the operational rules, PHI is governed by HIPAA, but when data is moved into research studies, it is no longer PHI. At OSU, we treat it as PHI. So we put all the rules and regulations around PHI currently on that data. But a good example is in a breach of PHI, we're required to report to the Office of Civil Rights. But in a breach of RHI, we are not required to report to the Office of Civil Rights. And that's because research data is not governed by HIPAA, it's governed by the common rule, right? And to be clear, another category that I always find interesting is FERPA, which controls all student health information. So it's not even PHI, even though you would think of it as PHI, because it's contained within the context of the university as a provided service, it's covered under FERPA. And so the legal frameworks really do make a difference in how you categorize and transact in this data. I will say we're trying to make things more transparent. So if you get, we are discussing this philosophy where if a patient gives you consent to use their medical record, then we should be moving the medical center out of the role of custodian. They've given their consent, and in fact, there's some legal precedent around information blocking that suggests if the medical center engages in loco parentis around your data, they're actually engaging in information blocking. And that idea that if patients own their data, they have the power to do with their data what they want. And so while we might like the idea of protecting patients from themselves, it is, there are raised concerns in the Office of Civil Rights around our ability to do so because it constitutes information blocking. We're looking at providing automatic data delivery to people who have consented to studies where there is documentation of a HIPAA consent. So you'll be able to get a standards-based data model out of EPIC. And I'll finish with this discussion about partner. When I started, there was at OSU the Total Cancer Care Protocol. And the Total Cancer Care Protocol effectively is that universal protocol that basically is the opt-in to everything protocol. And interestingly enough, 95% of people who show up to the cancer center who are asked to participate in the Total Cancer Care Protocol sign up for the Total Cancer Care Protocol. And so 95% of people who are getting services at the cancer center have opted into a broad consent around research. And we are in the process of doing the exact same thing across our entire medical mission. And the logic that we wrote in the very beginning of this was, it's easier for you to share all your data with Facebook, who has no controls and no regulations on their use of data, than it is for you to do it in the medical center. And we actually have structures and policies to do that. I'll just finish up with, there is one difference between TCC and partner, and that is TCC allows you to actually not only, well, it's a biospecimen and data repository, but TCC allows you to share data across research studies about a patient. So if I'm in a research study and then I go to another research study, those two research studies, I'm asking for permission to share not just clinical data, I'm asking for permission to share research data. And this really is a frame-breaking approach to the way that data sharing happens in the university, because we took the idea of broad consent and said, well, then what do we need to put in place to facilitate discovery to the greatest amount possible? And then what constraints do we have to put on it to be respectful of our obligation to use that data respectfully? And with that, I'll stop. Dana, you're on mute.
Thank you. So now, why don't we let Efthimios go first, and then Amanda, just sort of your quick thoughts both on Kayte and Tim's presentations.
Okay, thanks, Dana, and thanks very much to Kayte for joining us from far away Ann Arbor and sharing her ideas. And I want to just really highlight her recent piece in the New England Journal was really a wonderful article, and I think a must read for anyone who's thinking about these issues. So, and I appreciate Tim's kind of sharing also what we're doing here at OSU. I'm going to pick up just for a minute or two on Kayte's last slide when she was talking about potential solutions. And I think that the solution is different for different stakeholders. So I'll focus on, I guess, kind of three research areas: universities, industry, and government. At the university level, a lot of this kind of falls on the IRB. And I think what Kayte was describing at the University of Michigan, there's no doubt that the IRBs need to go beyond the legal requirements, right? So any of us who have served on IRBs knows that a lot of times it's just kind of checking the boxes and making sure that the legal regulatory requirements are met. But that just doesn't account for the way that data is used today. And especially, I think when you think about the triangulation of data, right? So it's not just what are we getting through patients, it's how Facebook is contracting with the university hospitals and 23andMe and Google with search and all this publicly available, not publicly available, but outside of HIPAA data, that's what makes this ethical calculus extremely complex. And I think that's what makes the onus on the universities to look beyond the legal requirements. So again, going beyond the IRB legal requirements, I think is essential. For industry, I think a lot comes down to industry taking it on itself. I know it's a lot to ask to have some sort of data ethics officers, data ethics departments. Of course, industry is unlikely to make any moves unless they're legally required to do so. So one idea I've been kicking around, I'm trying to put this into an article, is to try to see if there is a way to work current negligence law, right? So sort of duties that companies owe to the community, to their clients, to their customers. And one way that this type of claim might be raised is if you are, let's say, a data holder, right? If you're controlling data that's outside, this is all outside of HIPAA, there could be a claim that the failure to exercise reasonable care in conducting an ethical analysis gives rise to a legal claim, right? In other words, there's a legal duty to conduct an ethical analysis. So that might be one way that individuals can hold companies accountable for looking beyond the legal requirements. And the last point I raised in government, and I think some areas in government are making a move, again, looking beyond legal requirements. So I'm on an IRB that is centered at the NHLBI, the National Heart, Lung, and Blood Institute. And it's called a Clinical Data Science IRB. And basically it's the first of its kind at the NIH. And basically what we're trying to do is to conduct IRB review for data use requests that don't have a legal mandate to have IRB review. In other words, a lot of the stuff that Kate and Tim were talking about, things that are outside HIPAA, maybe they're research health information, like I like that term that Tim brought up, where again, it's outside the PHI definition. But again, NIH, which has, you know, a treasure trove of data, is really recognizing the limits of the legal requirements and trying to construct ways to think more ethically, more broadly about what should be done, how this data should be shared with industry and with academic researchers. So I'll stop there. I'm looking forward to hearing Amanda's thoughts and to hearing the Q&A.
Hi, I'll just jump in. First, I want to thank everyone for proposing solutions. I think that's marvelous. I think that characterizing the problem is actually a challenge from all these different aspects. So I'm really thrilled that we got that done wonderfully well, and now we're moving on to solutions. I hope to add a little bit to that conversation. So my previous background at 3 different institutions was as a data librarian, where I was specifically tasked with helping researchers share their research data according to new funding mandates, right? If any of you are aware of sort of the sharing policies out there, the data management plans. So really wasn't thinking about ethics. And through about 8 years of doing this, kept running into situations that actually echo a lot of what's been characterized so far. There would be no legal framework for dealing with what we were looking at. Generally, someone would end up in my office if they had a suspicion or intuition that they should not be sharing their data, but they were feeling a lot of pressure to. So I started getting interested in looking at it from an ethical standpoint, that whole benefit versus harm, right? You go back to the basics of, you know, who does this hurt if we share this data? And had a lot of experience actually outside of the healthcare realm. So I'm glad to see that healthcare is sort of taking the lead on this. And I'm hoping we can take some of the both technical solutions and sort of the principle-driven solutions and transfer that into other research realms. I started teaching a little bit of data ethics, and what I found is that there's not a lot of consensus in the communities I was talking to about what should be done. So we're lacking a regulatory framework often. We're, you know, as humans analyzing the situation, realizing that harm can come out of some of this sharing. There's very good reasons not to share a lot of research data, whether it's small or big or whatever technical shape it's in. So I started to realize that we needed to catch the researchers younger and start putting these principles in front of them and challenging them. Now, I don't know that I have any consensus from any particular research community, because it does seem to be largely contextual. What kind of data and what are the standards and what is the acculturation within that research community to what should be shared when and what kind of harms might come out of it. So I hope to add to this conversation that educational programs to ourselves might really be beneficial and helping us stop being reactionary. You know, hopefully we're not all sort of doing salvage work as we realize we shared something that was going to have unintended consequences, or we didn't have the right data use agreement on it, or we didn't know that it should have a data use agreement. And start preparing our young researchers in particular to approach these things before they get too far into their programs.
Great, thank you everyone. And so there's a lot that we could talk about. So I'm gonna start with a few questions, but I see that there's already some people that have asked questions, and thank you, Tim, for answering one of the more technical questions about how this actually works. Please feel free to write questions in the Q&A right now, and we're going to get to those in a bit. So one thing that I think is interesting, and it might lead to an interesting discussion where we compare like University of Michigan versus Ohio State in terms of like the policies that have been implemented. So one of the things, Kate, that you mentioned was about commodification, and this seems to be actually like commodification and non-welfare interests seem to be like two main issues beyond privacy and sort of harms done from one's privacy, like from identification of data, that are still issues for people, right? So even if your data is completely de-identified and protected, there still seems to be this worry that certain companies or certain institutions are going to be making money off of my data. And so I'm just wondering, and this is a question for everybody, you know, how should we think about the commodification of data? Are there certain kinds of personal information or data that we should refrain from commodifying? Who and how should people be compensated for the data that is shared? So I open the floor, and if people are jumping in, then I'll start appointing people. So does anyone want to sort of get a first shot at that question?
I'm going to talk about a struggle I literally talked about today. And that is that there are a number of companies out right now that are moving from purchasing services to sharing data as payment for services. So a good example is I have a digital pathology vendor who has built actually Nationwide Children's built a system that they've and the system itself is now commercialized. And basically what they're doing is it's like an image viewing service for research. So you upload your images from your digital pathology images, and then you can share your data. And there are a lot of services that researchers actually need. And we don't have good tools in order to deliver those services right now. And then you're stuck with, but in order to do this, you have to agree to let them to have your data, the data that you upload. So now you're in this environment where there are no service alternatives. I actually went to one of these vendors and said, we'll pay, tell us how much it costs. And they're like, that's not our business model. Our business model is to leverage the commodified data. So one of the challenges I think we have to deal with is the fact that because third parties have built infrastructure and are building infrastructure around using this because they don't believe that people up front will pay for these services, and they don't have the capacity to build it on their own, what do you do if you need those services?
So I will second everything Tim just said, and then to make a different point, but I am in complete agreement with that. I think that your question hones in on one of the major failings of our current human subjects research regulations, because the research regulations were written in response to the Tuskegee syphilis experiments. And they're very much written in response to types of experimentation where the risks were physical and adverse effects were profound, right? And we're still applying that regulatory structure to secondary research with data and specimens. And one, even if they're identified or de-identified, like the risk of privacy is a completely different kind of risk, right? Then like it's a non-welfare kind of risk, like however you want to describe it, as opposed to like the risk of being physically injured. And so it's just, there's cognitive dissonance between applying those sort of very stringent regulatory structures on this sort of very low risk work, in terms of sort of privacy violations, non-welfare interests, and commodification. And you're right, people do feel strongly about it, but not as strongly as they want to protect themselves physically. And so we haven't really fully made that transition. Although I will add to our concerns about data privacy. And I think one component of it is that people don't think of data privacy in terms of holistically all of the data that's out there about them. And I think Efthimios brought up this point, which is that, you know, you might be comfortable sharing your children's pictures on Facebook and your work on Twitter and the type of person you're interested in dating on Tinder. But nobody's thinking about the fact that companies are, you know, there's this data mosaicing where companies are actually in charge of creating data sets about you. And it's really easy to re-identify you, your health data that might be de-identified if I can match it with your GPS data that shows me when you were going to what location on the University of Michigan, whether you're going to visit the midwives or you're going to visit the primary care physicians, right? And then matching it with the kind of person you're interested in dating and your children and your political affiliations. Like, this becomes very personal very quickly. And even, you know, Efthimios pointed out in his article, you know, Facebook has even looked into trying to recreate, and there are entire industries that do this. They create sort of shadow health records, right? Like they pull together all your information and they recreate your health record. And that is entirely outside of the auspices of the regulations. We can do anything we want with that. So yes, I see your problem and I compound it.
I'll just jump in for a second. You know, the commodification of these downstream data uses, it's not stopping, right? There's a lot of good that comes from it, right? Especially when you're looking at new innovations in medical care, treatments, et cetera. We're even seeing it from the public health perspective now with COVID, obviously. And I think, you know, like Kayte was saying, it really comes down to how the data are used, right? So, you know, the studies have shown repeatedly, people are less worried about healthcare companies using the data for innovation or academics using it for medical research, much more worried when the information is, you know, triangulated with Google and Facebook and Apple and all of a sudden ads are popping up, right? So even if there might not be, you know, a true harm, right, that's happened just because an ad pops up that relates to my health, people feel as if they've been violated. And I think that's what Kayte is getting at, is that it's a different type of harm that the common rule was built around, but no less serious.
So let me ask one final sort of question and then open it up to, there's some excellent questions that are coming on the queue. So, I mean, so this is just sort of piggybacking up off of what Efthimios just said. You know, it seems like even when, as Kayte was showing, like, you know, even when you go above and beyond the regulatory infrastructure and what is required, it still doesn't necessarily match up with not only patients, but also physicians and clinicians' expectations about how their data is being used. And so how should we think about balancing public, physician, and researcher hesitancy about data sharing with the potential of like scientific power and efficiency that the data sharing makes available?
I'll just jump in quick. I think that part of these questions, because they're not necessarily settled and they are very contextual and nuanced, is transparency and auditability and being able to go back and opt out or change the data set, essentially. And those are all very technically difficult things to accomplish, right? One of the things that we don't know about you know, data is how it's going to be used in the future when you combine this data with other things, that sort of thing. But I think it's very important to try. I think it's very important to have principles of transparency and trackability and auditability, and even you know, revising the data set, deciding, well, I don't want to be a part of this anymore, so I would like my data pulled out of it. I love some of the examples that have been given so far, and I think that the more this is talked about and the more that this is discussed within our communities, not just academia, but actually out in the mainstream, we're going to get better results, just because companies are going to be put under pressure to be more transparent. And you know, often the systems are set up so that you kind of surrender your data because you have something you want from them. And when there's not an alternative, or it's something that benefits you enough, you are more than willing to do so. Now, I would argue that without transparency, we might not know the true cost or the true value of what we're giving up. And so that's where I think if we started to work on that, it would get a little bit better.
So I'm gonna talk about a real world challenge around opting in and opting out. One of the concerns that we had at the medical center was allowing people to opt out of research, because opting out of research can have just as dangerous consequences as opting into research. Imagine that you're a patient who just is seeing their regular doctor, and you say, I don't want to be a participant in any research. They mark on your medical record, okay, this person doesn't want to be in research. 2 months later, you're diagnosed with cancer, right? All these investigational drugs are in cancer. You're not asked to join any study because you forgot you opted out to research. It's a lot, it's a lot more complicated than just a simple yes, no answer, right? We struggle as a medical center with the ethics associated with just the dynamic of opting in and opting out, because of the associated real world impacts on people's lives. And so I think we have to be careful about saying things like, well, it's about transparency, because in part that transparency happens at the point of the decision, right? I barely remember what I decided, a couple of weeks ago, yesterday. Like I literally can't remember, like, lots. And when you think about people making these decisions in a moment, it's the exact opposite of the example you gave, where you said, oh, you went back to people and had a conversation with them about, that you consented to these things. Well, what's the opposite when you say, I don't consent, I decline to give consent, and then they forget that they've declined to give consent, they've opted out. And so I worry about the ethics of opt-out systems.
Yeah, and I'll just add to that, because you highlighted really nicely potential bad ramifications for individual patients, but there are also big costs to systems to try to roll out and enforce those sort of complex schema necessary to allow individuals to opt in and opt out, right? I mean, this is the real concern with Francis Collins sort of scolding OHRP from not having reconsidered the biospecimen thing already in JAMA, right? Is that, so if they make all biospecimens inherently identifiable, one thing that we were thinking through in Michigan when we were worried that the regulations were going to do that is if somebody opts out of biospecimen consent, do they mean that biospecimen, like that vial of blood the day that it was gathered? Do they mean all biospecimens ever? Does it mean like when we take their tumor out from cancer 4 years later, they don't want us to enroll it in precision medicine, to your point? And also systemically, like, how do we tag that data in a way that doesn't cost us so much money that the collection of biospecimens is actually advances the research, right? If we're spending so much money to make sure that one person, like, their specimen as it falls through the system, like, doesn't get used, those are funds we could be using for research or for other things. So it is really a balance.
All right, so now I'm going to open up some time for some questions from participants, and please continue asking questions. If we don't get to them, we'll still have them recorded for the panel. So one thing is, this panel is being recorded and it's going to be posted on the Center for Ethics and Human Values website. And then I will ask afterwards if we could get the slides for attribution and sharing afterwards. So, so one question that I think is a quick one, but is an interesting one by Justin Smith, is this question about whether we should worry about the impact of non-random differences between populations that are willing to provide informed consent and those that are unwilling, especially given, Kate, what you sort of showed, there are potential racial differences in terms of who's willing, who wants an opt-out or an opt-in system versus an opt-out system. So should we be worried about that in terms of research integrity?
I mean, I can tell you that OSU is, and the strategy that we're putting into place is this idea of facilitating cross-database analysis, reducing the transaction cost associated with cross-database analysis, to allow you greater ability to ask your question or pose your analytic framework on other data sets so that you can leverage intersubjective reliability to help address those things. But I think it's an ongoing issue, right? If you say, I've discovered a phenomenon here at OSU and it therefore is generalizable, you know, there's all of this work on generalizability of research that came out of the psychology studies that certain people are familiar with about the non-replicability of research studies. And so that was the generative basis of NIH's rigor and reproducibility efforts.
Yeah, and that's a hard question, but I think one of the most important ones. And I think it highlights sort of one of the quintessential tensions here is between autonomy and ensuring the diverse generalizability of results from that work, right? So on one hand, if I'm working with a database where everyone consented, I'm respecting individual autonomy by ensuring that they wanted to be in that database. On the other hand, if I'm using just general de-identified EMR data from my university, electronic medical record data, that the university collects and allows me to do research with, it is highly likely that those data are more diverse. And in terms of race and ethnicity and socioeconomic status and insurance. So I think that COVID is actually a really excellent example that we should be thinking about right now, because as we know, the effect of COVID has been much more profound on communities of color in the US. However, the drug trials have been, like, they're touting 20% of all people of color enrolled as a major accomplishment, when in fact the rates of infection are often, people hospitalized are often more like 40%, and the rates of deaths are much higher. And questioning whether that's really where we should be on that, and whether we're, you know, the exploitation versus ensuring generalizability. I mean, it's quite complex. So I think that that's something we should be asking ourselves every day with the COVID research specifically.
So here's another question. Here's another question from Tanya Berger-Wolf. So in many cases, we, and I'm assuming this is also the research community, don't even understand the ethical implications of the data. For example, we're only now starting to understand the risks of genetic data. How do we start with mandating and regulating transparency even when we don't understand those risks? So how do you even formulate it in informed consent documents or in conversations? Any thoughts?
Can I speak up and volunteer, Efthimios? I'd like to hear your thoughts on that.
All right, I can't say no to our guest. So I think Tanya brings up a really important and interesting point. It reminds me of Donald Rumsfeld's kind of dichotomy of information, where there are known knowns, unknown knowns, known unknowns, and unknown unknowns. So I think what Tanya's referring to are the known unknowns, which are the things we are certain we don't know about, and even the unknown unknowns, the things that we don't know that we don't know. So how do we capture those? I think recognizing that they're out there is the first step, right? That we don't know all the points that could potentially go wrong or can be, could lead to have unethical implications. Beyond that, I think it comes down to creating some type of system of analysis, right? So the kind of the ad hoc system we have now, where U of M has their own protocols or Ohio State has its protocols, that's just not good enough, in my opinion. I think there needs to be some more kind of best practices set across the country that can help guide, let's say, universities or industry on how to think about the ethical implications. And I think a big part of that, or at least a part of that, needs to be what Tanya is highlighting, which is trying to recognize that we don't know all the potential negative, right? Because I guess that's what we're getting at, the negative harms that could result. But perhaps trying to capture them by, well, are there privacy concerns here? Are there concerns about justice? Are there concerns about exacerbating inequities? Are there concerns about, perhaps infringing upon a subpopulation's culture, right? Think the Havu Supai. So I think if we try to group these types of potential harms, then maybe we'll have a better job of capturing these. But of course, we're not going to get everything. But I don't think the get everything needs to be the goal. It just needs to be much more robust than where we are.
So I will ask one final question from Jake Earl. So ordinary folks seem to have diverse, inconsistent, and highly context-sensitive views about when and how their data should be used. Does this limit the utility of trying to design data policies that address people's concerns? Would it be more productive for industry and academia to just figure out a reasonable approach and just educate the public about its virtues?
So that's definitely what I would advocate for. Just to be transparent, I'm a data liberal. I think these things should be used liberally because of the value of potential advances as compared to the risk to the individual of non-welfare harms. So yeah, I mean, I think that is in fact one of the best solutions. Instead of, because when we're talking about human subjects research, like active, involved human subjects research, we're injecting new drugs, there's always a two-step process, right? The IRB has to say, is the potential risk worth the potential benefit to the participant or to future patients like them? And I think we have to do better on the secondary research with data and specimen side to also go through that two-step evaluation of, should we even be asking people if this is okay with them before then asking them specifically to enroll or not, given how much we know about how little people understand the informed consent forms. I think we can further raise the baseline of what those are allowed to say in the first place. Because we know that just disclosure doesn't work, and we know that people feel really strongly about commercialization, but there's no perfect solution.
One of the approaches that I'm trying to build the infrastructure to use is the ability to, we've seen the rise of technology as technology-mediated consent. And so we're working with a vendor right now to create a video system where you could click a button and talk to someone about consent, so that you're actually talking to someone that is not related to the study in a separate environment, and reducing conflicts of interest. And we're going to be potentially playing with that infrastructure to understand if we can get higher quality, people feel better about the fact that they can do that, right? Which goes to some of the other questions here. I think one of the challenges that we face is oftentimes the decision to do these things happens in the context, at least in a health context, at a point of care, not the point of care, but a point of care. And that people may not feel like they have agency in that moment to have that conversation with their doctor who's sitting in front of them and saying, hey, I have this study, and being able to break that relationship so that we can focus more on having someone who's had a lot of practice talking about consent, engaging with potential participants.
I love the idea of using technology to more rapidly communicate with the ordinary person, particularly with regards to the benefits of sharing their data and the research results. I think that our system is necessarily very complex. Research results often, are very technical and don't you know, people don't know when their data is being used for a breakthrough, right? Like the time span there is so long. But it's reminded me of a system, and I regret I don't recall which country does this, but they have a little system that when you donate blood, whenever your blood is used, you get a little text that says, hey, your donation was used today. You know, something as simple as that is a reward. And we've seen that ordinary people turn over vast quantities of their personal information for very little reward. You know, so if we could somehow tap into that motivation for them, I think it would also spur their curiosity into understanding more about how their data is used, and do it in a very positive way, as opposed to sort of a scandal-ridden negative way that generates mistrust. So, so yeah, I'd love to see innovation in that area happen.
I think IT, at least at OSU, is doing a great job of helping to start outline and construct infrastructure that's going to make OSU a leader in this kind of stuff moving forward. And they're doing it in partnership with researchers to figure out, with the IRB, I've been looking at the list of people who are here, and I'm like, oh, Sandra Meadows from Regulation and Compliance at IRB is here, right? Like, I'm just so happy to see the partners who are talking about these issues on a regular basis joining us in these conversations.
I think that is probably the perfect way to end this conversation. I am very excited that there are many more solutions that were proposed than often there are when we talk about some of these really complex research ethics and research integrity questions. And the questions about like autonomy, and also the question about reproducibility and sort of the ethical responsibilities of researchers to ensure that there's generalizable research that is maximized. Being good stewards of your data means maximizing the sort of use of that to have generalizable results. And so I'm going to plug, we did last year, I believe, an ethics of reproducibility in research that is on the CHV website. That was also a really terrific discussion. So please feel free to go there and look back on other taped recordings of past discussions. And thank you so much for all of the panelists today.
Thank you, Dana. Thank you, everyone.
Thank you for having us.
Thank you.
Thank you very much.